Have you ever had a cuboid-related case that didn't resolve as quickly as you thought it should? Do you sometimes wonder, what the hell is going on? I sure have, and I'm sure you know how unpredictable some cuboid cases can be. I've certainly had my fair share of frustrations over my 30-plus year career as a health practitioner. G'day, I'm Ted Jedinak, International Educator of Manual Therapies for the Lower Limb and founder and director of the Foot and Leg Centres here in Australia. I help health practitioners discover how to get better clinical results for your patients. It's all about giving you the best tools and strategies so you can get confidently even better clinical outcomes. In this module, I unpack over 30 years of experience at the coalface of the consulting room. The crucial information I'm about to give you on freeing stuck cuboids for the long term has been tried and tested by not only by me, but my students all around the world. These specific strategies have literally transformed the way thousands of practitioners tackle cuboid-related conditions. In this lesson, you're going to find out 1. Why cuboids get stuck in the first place and how this affects the symptoms your patients suffer. This is going to help you enormously in choosing the right treatment options for your patients. 2. The most effective cuboid mobilization techniques for releasing stuck cuboids. I'm going to include both supine and prone treatments so you have the greatest versatility in helping your patients' problems. 3. How to design cuboid exercise plans to release stuck cuboids for quicker symptom resolution. 4. How to accurately assess and determine the optimum position of a cuboid notch pad so patients get better clinical outcomes that last for the long term. In fact, I'm going to include the exact exercise plans we've been using in our clinics for over 2 decades. You'll be pleased to know that practitioners all around the world who use these exercise plans are getting the same results that we achieve. It doesn't matter what language you speak. You'll be able to use these exercise plans in your own clinic straight after you've watched this video. There's a clear-cut, step-by-step process will revolutionise how you prescribe exercises for cuboid-related cases. Your patients will love you for it. Plus, it'll also take the guesswork out of everything and make your life so much easier. Geez, I wish I'd found out about this stuff a lot sooner in my career. It would have helped many more patients as a result. So, before we launch into the mobilisation techniques, you need to be crystal clear on the biomechanics of why cuboids shift or displace in the first place. In my experience, it boils down to 2 key factors. The first is the anatomical design of the cuboid and its articulations. The second is the fact of the biomechanical compensation patterns that commonly occur with the cuboid. So for the next few minutes, I'm going to give you a succinct anatomical and biomechanical explanation for lateral foot pains that friend and colleague Brenton Bowen described as the best explanation of lateral foot pains I've ever heard. Let's begin with the anatomical facts of the cuboid. When you look at the cuboid, you can see that it articulates with the calcaneus, bit of the talus, navicular, lateral cuneiform, and then there's the bases of the 4th and 5th metatarsals. So that's up to 6 bones that articulate with the cuboid. Then there's a bazillion ligaments, capsules, tendons that are all connected directly or indirectly to the cuboid. And this is why symptoms that come under the umbrella of cuboid syndrome can be non-specific in site, because you often get MSK irritations occurring at 1, 2 or more MSK structures connected with the cuboid. Hence, it's common for your patients to say, it hurts around here. Make sense? Great. So to help you understand what's actually going on, I'm going to reveal the most common etiological biomechanical pattern that displaces or shifts the cuboid from its optimum position. This is really important to be clear about because it'll help you understand what the problem is and what needs to be addressed to achieve the best clinical result for your patients. To do that, you need to quickly review the anatomy of the peroneal muscles, particularly the peroneus longus. Now this muscle literally uses the cuboid as a pulley, hooks around the lateral beam, past the cuboid and inserts into the base of the 1st metatarsal. Functionally, we know when the peroneus longus activates and the foot is in a closed chain weight-bearing state, the peroneus longus generates a plantar flexion moment on the 1st metatarsal. In simple terms, this means it literally stabilizes the foot onto the leg. Now, as long as the forefoot is locked onto the midfoot, which has a stable rear foot, this effect happens beautifully. Generates a supinatory moment in the foot, preparing the foot for push-off phase of gait. But what happens in the most common compensation pattern that you see in your clinic? Oh, hang on. What is the most common compensation pattern of the foot? Well, as you know, it's the pattern of the excessive pronation of the subtalar joint. When the subtalar joint's pronated in mid-stance, what does that do to the locking or the stabilizing mechanism of the mid-tarsal joint? Does it lock or unlock the mid-tarsus? Well, as you know, it unlocks it. Okay, now if the brain receives feedback from the proprioceptors around the foot and ankle that things are unlocked or unstable, it's like a loose bag of bones, what will the brain do about that? Well, it'll try to rectify the situation, won't it? It'll go, things are unstable and they should be more stable. I better do something about that. And what can the brain recruit to stabilize the foot? Muscles, that's what. And what muscle is the primary stabilizer of the foot? The peroneus longus. So now we've got the brain sending a whole pile of impulses down the corticospinal tract to activate the peroneus longus to stabilize the foot onto the leg. But the force of body weight pushing down on the pronated subtalar and mid-tarsal joints is way greater than the peroneus longus can counter. I mean, the peroneus longus could possibly generate 12, 15, maybe 20 kilograms of force. But you've got a body weight of anywhere from 60, 80 or 100 plus kilograms. So at best, the peroneus longus might be able to generate up to 20% of the force required to achieve the brain's goal of stabilizing the foot. It's grossly ill-equipped to complete the job. Actually, it's not even supposed to be able to do that job under those circumstances. But here's the kicker. Even though it's ill-equipped, it won't stop trying. That's right, it'll keep working and working until it's exhausted. And of course, that's when your patient comes crying to you for help. So now we've got an unstable bag of bones under the load of the whole body weight and a muscle, the peroneus longus, being stimulated to try and counter those damaging forces. What does the peroneus longus hook around? The cuboid, of course. If we have an overactive muscle hooking around an unstable pulley, what's going to happen to that pulley, which in this case is the cuboid? Well, it's going to be displaced or shifted from its optimum position, isn't it? And in what direction do you think that displacement is going to occur? The tendon hooks around this way and it pulls on the cuboid while it's unstable, and it'll tend to move like this, generally in an everted direction, meaning in the frontal plane, the plantar surface of the cuboid faces away from the midline. Make sense? If my fist is the cuboid, it moves like this. And if the cuboid gets displaced, what's going to happen to the periarticular structures around the cuboid? What's going to happen to the joint surfaces of the cuboid and the articulating bones, the calcaneus, talus, navicular, lateral cuneiform, fourth and fifth metatarsal bases? Well, they're going to have to compensate somehow, aren't they? And it's that compensation that leads to the symptoms or pains people feel. So let's summarize this crucial point of etiology. 1, the peroneus longus hooks around the cuboid anatomically. 2, the peroneus longus is an important stabilizing muscle of the foot. 3, the common pattern of excessive subtalar pronation destabilizes the foot. 4, the proprioceptors tell the brain the foot is unstable. 5, the brain tries to rectify this fault by stimulating the stabilizing muscles, including the peroneus longus. 6, this excessive stimulation can force the cuboid to shift or displace from its optimum position. 7, displacement of the cuboid causes compensation of the associated periarticular structures. 8, this compensation can cause symptoms or pains of the musculoskeletal structures associated with the cuboid. And that, dear viewer, sums up the most common biomechanical etiology of cuboid pains that I've seen in over 30 years of clinical practice. This biomechanical understanding of the etiology of cuboid-related conditions is an essential concept to grasp because it'll have a very clear impact on exactly how you treat cuboid-related conditions. Hey, I recommend you review this video because just like when you see a movie for the second time, you pick up details you missed on the first viewing. That's my recommendation for you for now. Watch this clip again. Having a clear understanding of the most common etiological pattern of problem cuboids will set you up brilliantly for the next video in the treatment techniques that we're going to use. Until the next lesson, serve with spirit, consult with care, and help more cuboids today. In this lesson, you're going to find out 1. Why cuboids get stuck in the first place and how this affects the symptoms your patients suffer. This is going to help you enormously in choosing the right treatment options for your patients. 2. The most effective cuboid mobilization techniques for relief. Have you ever had a cuboid related case that didn't resolve as quickly as you thought it should? Do you sometimes wonder what the hell is going on? Of the foot and leg centres here in Australia. I help health practitioners discover how to get better clinical results for your patients. It's all about giving you the best tools and strategies so you can get confidently even better clinical outcomes. In this module, I unpack over 30 years of experience. I sure have. And I'm sure you know how unpredictable some cuboid cases can be. I've certainly had my fair share of frustrations over my 30+ year career as a health practitioner. G'day, I'm Ted Jedinak, International Educator of Manual Therapies for the Lower Limb and founder and director at the coalface of the consulting room. The crucial information I'm about to give you on freeing stuck cuboids for the long term has been tried and tested by not only by me, but my students all around the world. These specific strategies have literally transformed the way thousands of practitioners tackle cuboid-related conditions.